Hi, everybody. This is Ben Bob Rowe and Dan Spate, Bruce Barnhart, Mike Sotelo. We're here with the EPIC team. I'd like to welcome everyone. We have a great group. We see there's already about 35 people that have tuned in. So we're just going to start to get set up, and 41 people, and the number is rapidly climbing. So I want to welcome everyone. This is one of our ongoing EPIC TBI webinars, and we have some great stuff for you today. We are going to have this archived. The presentation will be archived, and we'll distribute that, and that'll come out tomorrow. And people will be able to get, pre-hospital providers will be able to get continuing education credits for that. And we're going to put a link on the Department of Health website as well, so people will be able to see that. I just want to welcome everyone. Dan, you want to give any introductory remarks?
Yes, actually, Mike, are we giving them information on how they're able to send questions in during the thing?
Yeah, so if everyone will just hold their questions and put it into the chat, we'll address it at the end of the webinar.
Right, so go ahead. As questions come up during the presentation, just go ahead and send those in. And then we're intentionally stalling a little because there are people still rapidly joining, so we don't want to have to start over. We're approaching 50 now. And so let us go through the schedule. What we're going to start with is a very brief review of EPIC. Since probably almost everybody joining is familiar with EPIC, Bruce will give us that, and then Ben's going to jump right into some amazing stuff that we've been finding with monitoring of patients. Then we're going to talk about the absolutely amazing new findings about hypotension, if you will, in traumatic brain injury. And then we're going to talk through some specific cases that have come up that are very instructive. And then, as you can see, we're also going to spend some time making sure everybody knows how to access the new EPIC app, and we'll actually show you what's going on there, and then the other resources, the updates, and so forth. And then, again, throughout, feel free to send in questions so that at the end we can actually deal with the questions. So I think we're ready to go ahead and get going. And so I'll turn it over to Bruce, and take it away, bud.
All right, EPIC was started as an NIH grant about 3 years ago. We want to implement the evidence-based guidelines across the state of Arizona throughout all of Arizona. We have worked very hard at doing that, along with the efforts of countless agencies across the state. We've implemented the evidence-based guidelines that were originally put forward by the Brain Trauma Foundation many years ago. We are evaluating outcomes based on those guidelines with data that we've put in from all the agencies. We started the project, actually the data goes back to 2007 and will continue up to about 2016. We started training in 2012. We continue to train everybody that we can possibly find across Arizona. And then we're doing an analysis that we are in the process of collecting the data and analyzing the data on right now for our interim analysis. And our final analysis will be done in 2016. So we're doing ongoing data collection and analysis and training. So what kind of progress have we made? We have over 100 certified agencies across Arizona. About 87% of traumatic brain injuries statewide are now cared for by EPIC agencies, EPIC trained and certified agencies. We have over 9,000 providers that have been trained across the state of Arizona and certified in EPIC care. We're continuing to train and retrain those folks because it's very hard to remember everything that a person gets over time. So we're constantly reinforcing it as we are with this training here. When we get done, we expect to have somewhere around 26,500 cases enrolled in EPIC or data collected on that are in EPIC. We'll have about 3,500 intubations. We'll have a very large data set that we'll be able to ask very many interesting questions. We're just starting to get a few hints of data back that we'll talk a little bit about. And some of the things that are really important to remember is to always use ventilation rate timers. whenever a TBI patient is bagged or any trauma patient is bagged. Always use flow-controlled bags. And end-tidal CO2 monitoring is very good, whether it's nasal cannula or via endotracheal tube. And ventilator use probably minimizes some of the problems that we have. Problems that we are looking to avoid is the 3 H bombs, which is hypoxemia, hypotension, and hyperventilation. I'll go ahead and turn this over to Ben.
All right, thanks, Bruce. So we're using the sandwich methodology for training here. We're giving you exactly what you really need to know at the beginning. We're going to talk about sort of some of the details and meat in the middle, and then we're going to end again with exactly what you need to know. And so we got a lot of great stuff to go through. This is some of the meat. One of the things, of course, that Bruce mentioned, one of the primary drivers of EPIC is ventilation. And we want to kind of go over some of the details of ventilation, particularly end-tidal CO2 monitoring. And this is a lot of the things that we've learned in the last couple of years with implementation that I think you really only learn when you really start to try to do it. A lot of people talked about end-tidal CO2. You know, it's in a lot of guidelines, but we've learned a lot as we've tried to actually implement end-tidal CO2 measurement, continuous measurement. And what we've really found, at least at the beginning, at the outset of EPIC, was that there was a lot of sort of superficial end-tidal CO2 measurement. And it's what Dan liked to call ETCO2 monitoring that isn't. And so a lot of people sort of thought they were doing end-tidal CO2 measurement. A lot of people were doing very kind of superficial and perfunctory measurement, even just colorimetric measurement for tube placement. I warn you, the stuff I'm going to talk about is really, really difficult to do in some cases, but it's probably what ultimately we believe will save the most lives. And so what I'm going to talk about is some of the detailed end-tidal CO2 findings that we've had. And I want to preface this with saying that these agencies that have collected these data with us are, I believe, and we all believe, actually some of the most progressive and efficient, high-performing EMS systems anywhere. In fact, I would pit these agencies against any EMS agency around the country. And one of the things they've been able to do is actually collect these really detailed waveform event records from what's going on. And we'll show you this stuff. But again, there was a parental discretion here, so be careful what you're going to see. This is what that you actually see, what we saw, and what anyone would see early on as you start to try to really measure how we're doing with ventilation. This was just an early capnogram that you can see that on the top bar where the end-tidal CO2 was far below that green level of where it should be, and the ventilatory rates, as you can see on the second horizontal graph, were way above that green sweet spot. This is almost ubiquitous if you're not measuring carefully. I'll also throw out, and maybe be a little controversial, but this is what you see in the hospital as well. And we're finding that out ourselves, and I think a lot of people on the call who have been early adopters have seen this, and they've really focused on improving their care, only to find out when patients get into the hospital, oftentimes the care sort of reverts back to, what do you call it, Dan, to mama, yeah. to what you used to know and what's the most familiar. And so this slide is intentionally meant to not be subtle. This is what we are advocating, is that end-tidal CO2 is the path to improvement, and monitoring it carefully, really monitoring it, continuously monitoring it, and actually feeding back those data to the providers so that they can learn how they can improve. This is probably, we believe, the easiest way to harm patients, and that happens everywhere around the country every day, and it's happening less and less in our system because of EPIC. So really what we're focusing on is careful, continuous, meticulous end-tidal CO2 measurement. Now this is a graph that we've had since EPIC has started in some of those high-performing systems. And I'm going to mention some of those systems which are really our colleagues up in northern Arizona throughout the Guardian Multisystem, Mark Venuti and his team up there, as well as Mesa Fire Department. And they've taken this on as a real challenge to carefully monitoring all the aspects of Epic care, particularly ventilation, and really, really improving it. And you can see this example. This is just sort of that perfect example how the ventilation started out on the low side, on the high side, and Untitled CO2 was on the low side, but then it really rapidly was corrected. And so I want to, again, really thank those agencies, Guardian, Mesa, and our friends in Glendale, because they've really gone to the extra effort of trying to monitor and collect these data and use the data for quality improvement. So this is kind of the name of the game. Is it is a lot of things in medicine. You cannot improve what you can't measure, and we didn't make that up. That really is an old adage that I think is true with TBI and all aspects of emergency medical care. That we really need to be able to measure what we're doing and actually critically look at what we're doing to improve it. This is what the Brain Trauma Foundation guidelines and the NAEMSP TBI guidelines actually say right now. And again, this isn't, Epic is focused on implementing the guidelines. We didn't set these guidelines, and this is what the guidelines say, and that is that these key performance things and vital signs, blood pressure, SpO2, and end-tidal CO2, which I'll really argue is a vital sign for ventilated patients, should be viewed as a vital sign. These things should be measured every 5 minutes. And so as we're talking about that, one of the early questions we wanted to ask is, in our highest performing systems, how well are we actually doing that? And again, what I want to preface all of this is that these are the premier systems that are able to even measure these things and look at them. And there's a lot of real-life challenges to doing this. But when we looked at a sample of cases, 74 Epic cases, between basically 2012, 2013, kind of the early onset of implementation, we found that we were able to actually record and report vital signs every 5 minutes in about 62% of the cases. So it's really challenging stuff, as I said at the beginning, but this is the stuff that actually makes the difference. When we looked at end-tidal CO2, we were interested in were there any differences between sort of what was recorded on the manual PCRs and what we found when we looked at those at the actual monitored data, the beat-to-beat event data from the monitor. And this is what we found, that out of 26 cases where we had end-tidal CO2 documented, that in 17 of the cases with the PCR, it was actually recorded that the end-tidal CO2 fell below that key threshold of 35, whereas when we actually looked at the monitor, about 21 of the cases, about 80%, had a drop to 35, and as well, when we looked at systolic blood pressure, these were the numbers. And so these, while these are not statistically significant, in another 5 patients in this sample, we actually found drops in systolic blood pressure less than 90. Again, sort of our key threshold for blood flow during TBI care. This one, looking at the third component of oxygen saturation, we saw actually a pretty dramatic difference in the number of events that were documented on a PCR as dropping below 90 compared to what actually was recorded on the monitor defibrillators. And this actually was statistically significant. So what we actually think is that this stuff's just really, really difficult. And again, we want to compliment and really congratulate these systems that are going to all the work to actually do meaningful, ongoing, iterative quality improvement work. And this is just a sample, just so some people, the reason I put this up is I want some people to get a flavor of what's going on in these systems, Guardian, Glendale, and Mesa, where they're actually doing very robust quality improvement for each event, and then feeding those data back to their providers for feedback and improvement for future cases. And so it's a brief process. It's not, you know, extremely long, but they're doing it on every case. And now you can see this is the type of data that they will see, and you can see this is just one example. Again, this is a real TBI case where you'll see that they managed to keep the systolic blood pressure above that threshold, actually well above the 90% threshold. The O2 saturation never dropped below that 90%, and as we know, just one episode of a non-spurious O2 saturation is associated with a doubling of mortality, so they avoided that. And then you can see how nicely they maintain the end-tidal CO2 in that target range. So this is just sort of one of the great things that we're starting to see as we look at more and more of these event data. So really kind of the take-home message with end-tidal CO2 is that it is the path to truth. It is the path forward, and that we need to meticulously follow it, as well as using the other two key tools that we've talked about, which are a ventilation rate timer that actually, if you don't have end-tidal CO2, and even if you do have end-tidal CO2 before you start using it, this ventilation rate timer can help you get on that correct ventilation rate. And it's so incredibly easy to hyperventilate. It basically almost always happens both outside and inside the hospital without these adjuncts. And the other thing there you see are the pressure control bags that actually prevent excessive pressure and excessive volume. And so all of our EPIC agencies that have done this training are using these now and have gotten these tools. And again, what we believe is all these tools in combination are required to prevent that almost universal hyper and over ventilation. And so, again, the take-home message with our ventilation is that if you have end-tidal CO2, it needs to be used and really be used, not just kind of monitor it, but forget about it. It has to be used as often and as continuously as possible. And these other adjuncts, both ventilation rate timers and flow control bags, need to be used. And without them, we really believe that without using those, this, doing advanced airway management and intubation without these devices is actually a downgrade from BLS. So we're really, really encouraging people to do these. So I'm going to shift gears quickly and talk about sort of a common sort of question and issue that we've gotten quite a bit. So, when you look at end-tidal CO2, just sort of the quick down and dirty physiology of end-tidal CO2, that, we're measuring the partial pressure of carbon dioxide at the end of exhalation. It's really basically a function of three things: of cellular metabolism and ventilation, but also cardiac output and blood flow. And it's a great tool for all those, for actually monitoring all those things. And really, end-tidal CO2 is a direct measure of ventilation. It's sort of an indirect measure of cellular metabolism and cardiac output, but it's an important tool to use, that all those three things are involved with end-tidal CO2. And the reason I bring that up is we've had, a lot of people have the discussion about using end-tidal CO2 when patients have hypovolemic shock, when they're actually in hemorrhagic shock. And we just want to mention that end-tidal CO2, because blood flow is a major contributor to end-tidal CO2, if there's shock and hemorrhagic shock, there's obviously not as much blood flow getting to the pulmonary system, and so end-tidal CO2 levels will be lower, and in fact they can often be unreliable. And so the real take-home message is, if you do have a multi-system trauma patient with both TBI and hemorrhagic shock, that what you need to do is to stick with the targets for ventilation rate, and if you see the end-tidal CO2 precipitously drop, that likely may be, and you have to use your clinical judgment, that likely may be a sign of hemorrhagic shock, especially if you're sure that you're controlling the ventilation. And so this is sort of what, again, what an end-tidal CO2 will look like. And if you see that end-tidal CO2 dropping and the ventilation, and you're keeping the ventilation steady, you have to suspect that that's actually related to hemorrhagic shock. So that's really the key take-home thing. We want to just illustrate this with a quick scenario. Say, for example, you're ventilating a patient at 10 breaths per minute according to the guidelines with the right amount of tidal volume, and the end-tidal CO2 has been closely and steadily regulated around 40, and then you suddenly notice a precipitous drop in end-tidal CO2. What should you do? Really, the three main things are to carefully make sure that you are ventilating at that correct rate and depth, and that you haven't sort of inadvertently started to hyperventilate or overventilate. But really what that's likely a sign of is precipitous drop in blood pressure. And if you see that, the thing to do is to not to alter the ventilation, but to aggressively treat the blood pressure with IV fluids. If you believe that the patient's hypoperfusing due to hemorrhagic shock, you should stick with those target ventilation rates using your ventilation rate timers and the flow control bags. And so what we're saying is that you got to use clinical judgment, and that's what really our providers are so good at doing. So it's not just using end-tidal CO2 sort of in a vacuum, but using it in a clinical context. So bottom line, almost all of your patients should have carefully, meticulously followed end-tidal CO2, and you have to be very, very cognizant of the ongoing tendencies to hyperventilate. And again, if it's in the setting of a multi-system trauma patient, which it frequently is, you have to use some clinical judgment when you're looking at the actual end-tidal CO2 values. And that actually, end-tidal CO2 is a very early marker of shock. And so that actually, it can help you if you understand that. So I'm going to turn it over to Dan now. He's going to talk about hypotension, TBI, sort of the other, and some of the key findings that we've had.
Okay, so Ben was talking about some of the specific and very detailed subgroups. Now we're going to look at some early findings from what amazingly EPIC is becoming by far and away probably the world's largest TBI database when you talk about linkage to specific and highly detailed pre-hospital information. And the EMS agencies that are out there, you're the ones who are providing this, and we're incredibly grateful for it. But we want to show you some amazing and previously unknown in the world literature, as far as we know, findings that are starting to come out of EPIC, even in the retrospective data group. So probably all of you know that there's a boatload of studies that have looked at blood pressure, but essentially all of them looked at the impact of hypotension on outcome in traumatic brain injury. And essentially none of them have asked the opposite in question, if you will, of what's actually potentially the best blood pressure for a patient to survive. This is an intentionally incredibly busy slide to make the point that this is just the short list of studies that have shown an association between hypotension and TBI. But the problem with these studies is either they're very small or they're not linked to pre-hospital data. And so that's what EPIC is really going to be adding, and I'll show you some really amazing findings in just a second. But just for all of us to remember, here is the guideline currently, and again, this comes from the Brain Trauma Foundation and the National Association of EMS Physicians National and International Guidelines. So in TBI, you start with at least one IV, and you treat, and this is in age of 10 or greater. We won't clutter it up with the peds for right now, but the concepts are all the same. So you treat any BP that's less than 90 systolic BP with an initial bolus of 1 liter, and then continue to aggressively treat it to try to keep the blood pressure at 90 or above. But the question, of course, many have asked is in multi-system trauma, where you may have a person doing internal bleeding in another part of the body, will the fluids increase the internal bleeding when it hasn't been controlled yet? And many of you have heard this concept. It's been termed in the literature permissive hypotension. In other words, the way I think of it is just give them enough fluid to keep them alive until you get them to the operating room and can fix the bleeder, if you will. And the problem with that is in the entire literature, both the animal studies and the human studies, an exclusion criteria has always been traumatic brain injury. And so the entire concept of permissive hypotension was not developed from patients who have major traumatic brain injury. So why should we treat hypotension and TBI? I'm going to show you some amazing new findings in a minute, but just remember, first, the National Evidence-Based Guidelines recommend treating. Secondly, all of the permissive hypotension evidence excludes TBI for good reasons. And then finally, in most patients who have multi-system trauma with traumatic brain injury, it's important to remember that the survival is most often impacted by the traumatic brain injury. And so in a sense, if a person has a major TBI in the setting of multi-system trauma, in one sense, the TBI trumps the other issues. And the way we've thought of it is a live body with a dead brain is still a dead patient. Treating the TBI as the primary focus is probably the key. And then this stuff is really exciting. As you can see, we evaluated over 8,000 of our retrospective patients, so none of these are in the after group. These are all patients from our agencies around the state before implementation of the training and TBI guidelines. And what we did was we looked at the patient's lowest blood pressure in the pre-hospital setting, and we analyzed how that's associated with survival. And this is really striking. Notice, so this is just the raw data. If you look at the probability of survival, what's really interesting here is that the optimal blood pressure, and again, remember, this reflects the patient's lowest blood pressure. The optimal lowest blood pressure in the raw data is 136, but when we do what's called logistic regression, when we actually adjust for the severity of the cases and the other things that impact mortality, this is absolutely remarkable. And when we presented this at the National Association of EMS Physicians earlier this year, really kind of created a firestorm. Notice the best blood pressure in those 8,200 patients to have to survive a traumatic brain injury after adjusting for all of the severity issues is actually a blood pressure of 144. There's one other thing that I want to point out while we're looking at this data. If you just look at this slide from across the room, it's really a fascinating one. And again, because everyone before has had such small studies, they haven't had large enough numbers to be able to give curves like this with, as you can see, really, really tight confidence intervals. So this curve is really what the curve is. And notice the left side is essentially the effect of the blood pressure on the brain. In other words, if you get low blood pressure, it kills brain cells. The right side, though, is probably the effect of the brain on the blood pressure. In other words, if you have a really bad brain injury, as many of you have seen, you can get extremely hypertensive during the Cushing response. And so it's just fascinating to look at the curve. But here's what's really remarkable. Again, this is the raw data. And notice that the lowest point of mortality, or the best survival, is way, way farther to the right than 90, which has been the classic cutoff. Most of you know, in fact, if you've taken EPIC, you do know, the current treatment threshold is a blood pressure of 90. And many studies have used that as the cutoff. Again, those studies have all been small, so they couldn't treat it as a continuous variable. And so basically they compare everybody who's low, if you will, to everybody who's not low. But notice the hypotensive side of the plot. This is really significant. Notice that when you get to 90, you have already gone significantly up the mortality curve. And so the other thing that a lot of people have thought is the concept of, well, as long as we don't let them get below 90, maybe everybody will do quite a bit better as long as you just don't let them get really low. But this is really striking. Notice this, that between a systolic blood pressure of 40 all the way to 130, every 10-point decrease in blood pressure increased the odds of death by 11%. And that was as true for dropping from 130 to 120 as it is for dropping from 100 to 90. So our whole entire concept that there's some magic threshold below which you need to treat and above you probably don't, this has started to, in the editorial literature, if you will, to blow up that potential concept. So why has the literature missed this? And I've already talked about how because most of the studies are small, but the reality is we haven't been looking for it. Really all we've looked at is hypotension, and then you throw on top of that kind of the being enamored with permissive hypotension, where in essence low blood pressure isn't bad unless it's really, really low. This could possibly be wrong with traumatic brain injury. So in conclusion, the optimal range may be relatively narrow for systolic blood pressure, and it may be much higher than was previously thought. And then the 90 millimeters of mercury threshold may not be real. So notice the risk of mortality may not be that you have some special magic inflection point, but it may be much more continuous. And then finally, to be clinically hypotensive, if you will, may occur at pressures that are higher than 90. Now, one of the things that's important is this doesn't mean that we should try to be treating to get them to 140. These findings don't change the guidelines, but it probably does mean that 90 may be way too low, and in fact the guidelines themselves make that very statement, that they had to choose something, but that it may be significantly higher, and it looks like EPIC has actually given strong evidence of that now.
Well, that's amazing, Dan. So what you're saying is you're not advocating for people to change their actual treatment. You want them to stay with the treatment, but just have them understand how vital the systolic blood pressure is.
Yes, I think what we'll talk about at the end with the take-home messages is that probably it's important to not let them get down to 90.
Right.
So that concept of waiting until they've gone under 90 probably doesn't make sense. And if you see them headed that direction, you should begin treating probably.
Yeah. And the other thing is we felt strongly we wanted to share some of the early findings before we had the outcome findings, so people understand really how almost revolutionary the EPIC study and the EPIC database has become. So
because of the agencies. If we didn't have the agency's data, we literally couldn't find it.
So all the folks on the phone and the ones that are going to watch the webinar, we want them to understand how important their work has been. We have a new thing. We have an app that was developed specifically for EPIC, and this was done with the Ramsey Social Justice Foundation. But basically, you can go to the Apple Store and the Google Store, and you can download this for free. There's a link on the EPIC website, and it has all of the key and critical EPIC protocol information, so you can just have that on your smartphone. You don't need to, Bruce made a really, really nice training cards early on, and so we still are using those, but we figured a lot of people would like to have it even more readily available. So we called it Pocket TBI, so you can download this for free, and we just want to throw that out there. We've had several hundred people download it, and again, there's a link on the EPIC website, so people can get that. So I'm going to turn it over to Bruce now. He's going to talk about the next section, which he calls sneaky TBI patients.
All right, what we figured out is that there are categories of patients that people don't really think about necessarily as being very, very high-risk TBI patients. I started with one group that I'll talk about first, and then we'll expand to three others that technically four others that we've found are risky. So first problem is patients that have a high GCS. So this is a patient with a GCS of 13, 14, or 15, but end up being diagnosed with severe injury. These patients don't really look like they're very severely injured when you see them. They maybe got a concussion. You think, oh yeah, this is a patient that I'll just transport in and they'll be home in a day or so, be admitted overnight for observation. We found that those patients often have very severe injuries. Second patient is the patient that has man, should I intubate this patient or should I not? It's a trauma patient, they're right on the edge. We'll talk about those. Those are little risky patients or sneaky. RSI is a huge issue. We'll talk about that, and then we'll talk about pediatrics and also the elderly. So what have we found about high GCS? This, if you notice at the bottom, let's say a patient that's following commands, so he's got a motor of 6, but he's repetitively asking questions about the events. He doesn't recall what happened. What happened? Where am I? What happened? His eyes open to void. So this would be a GCS of 13. This patient looks pretty good when you first look at him. Is this an okay thing or not? And what we found is that they are not. 73% of patients that end up with diagnoses of moderate to severe TBI, their initial trauma center GCS scores is 13 to 15. EMS is no better at predicting it. The Glasgow Coma score is a great way to predict changes, or not to predict, to compare changes in level of consciousness. But it's not a tool that can predict whether the patient has a severe injury or not. Half of patients that we're finding with moderate to severe, actually these are all severe TBI by our diagnosis. So severe TBI patients on diagnosis, final diagnosis at the hospital, they never have a GCS lower than 15 in the field and at the initial trauma center evaluation. So these patients look great. They're totally alert and oriented, but they end up having severe injury. What our goal is that every trauma patient should be treated using EPIC guidelines. That will help prevent secondary injury in all of them. And even if you have a GCS of 15, if there's a mechanism of head trauma, consider them to be an EPIC patient until proven otherwise. You'll be very surprised at some of the patients that we're finding that have severe injuries. That 73 and 52%, that was also found in another study that's referenced on this slide. Very similar numbers. So, I've got a patient that I'm just not sure. Their GCS is down. Maybe they're in the 8 range, which is, as we've all been told, if they're less than 8, intubate. Should we intubate them? What we advise or advocate is using your best judgment, considering all the factors that you can think of that may impact this patient. But be sure and consider all alternatives. If you have an effective BLS airway, that might be the most appropriate tool that you have. It can be very effective. If you manage it well and don't overventilate and hyperventilate, you can minimize gastric insufflation, so they'll have a lower incidence of vomiting. You certainly could put down an orogastric tube to help decompress the stomach and manage them very carefully. This is probably more important if you have a short transport. If you have a longer transport, you're going to have difficult decisions that you have to make. But it's very important to think about your BLS airway and can this be an acceptable airway in this particular patient. The second alternative that you have, obviously, is a supraglottic airway like a King or an LMA or a combi tube. The problem is as soon as you put an advanced airway in a supraglottic airway or an endotracheal tube, you've just magnified your chances of hyperventilation astronomically. It doesn't change if you've got a tube that you can put a bag on, whether it's a supraglottic airway or endotracheal tube, your risk of hyperventilation is the same as soon as you put that tube in. So you have to meticulously manage those ventilations, use ventilation rate timers and flow controlled bags, and also put them on a ventilator as early as possible. When we try and intubate a patient, the process of intubation on its own often causes very severe hypoxia. We'll show you that in just a moment. And as I've talked about earlier, the risk of hyperventilation increases dramatically. The other thing we found at a hospital in Arizona was that when patients are attempted, when an intubation is attempted on a patient and it's unsuccessful, the risk of complication goes up astronomically with subsequent attempts. So your first attempt should be very organized and efficient and planned out so that you get the patient intubated successfully the first time. Shouldn't be the time that somebody's looking for suction because it's not readily at hand, or there's no stylet for the endotracheal tube. You should have your equipment ready and be completely ready to go before you try that first intubation. That also gives a little bit more time for pre-oxygenation, which may decrease our chance of hypoxia later on. If you're unsuccessful, the best advice that we have currently is to return to BLS or go to a supraglottic airway as a rescue therapy as early as possible. Don't keep trying when things are not going well. Some patients are obviously going to be difficult intubations. Some patients are not, but may end up being a difficult intubation. As soon as you realize that things are not going to go smoothly, go back to a simpler airway as early as possible. RSI. We're finding lots of concerns with RSI because of the potential for severe hypoxia during the intubation attempt. If you're trained and experienced in RSI, it can be an effective adjunct in intubation. But, again, it often causes severe hypoxia. It can cause hypotension when you're giving Versed and fentanyl. And pre-oxygenation is probably your best friend, but we haven't found it as effective in trauma patients as we would like. So pre-oxygenate early, pre-oxygenate as long as possible, but be very careful because your patient will probably desaturate faster than you anticipate. Use sedatives and opioids very cautiously, so Versed and fentanyl very cautiously. Consider about a quarter of the normal doses, especially in patients with very low GCSs because those patients are not alert, they're not oriented, and they have a much higher risk of any problems. Once you start an RSI, you're committed, and you can end up with a very severe problem that is harder to correct. So think about whether you're performing the right intervention before you do it. Doesn't mean that you shouldn't, just be cautious with it. This is a patient, another one of our tracings, that the crew did a great job on end-tidal CO2 and ventilation rate, as we see in the first two bars. But this was a patient that had pulse ox below 90% for over 2 minutes, and they got down as low as 65%, which lasted approximately a minute. This happened to be an RSI patient, but any intubation can cause this because when you're trying to intubate, it's very difficult to provide any supplemental oxygen or ventilation to the patient. So this patient had a much higher risk of death simply because he had a severe hypoxemic event. So be really careful with that. Manage those things aggressively and treat them as efficiently as possible in getting the tube in. Pediatrics. Pediatrics are fairly commonly injured. They have big heads with big injuries. Their small airways make them hard to intubate, and it's rare that a provider gets a chance to successfully get a tube in. The difference between life and death in a small airway is very little, because if the tube gets moved even a few millimeters, it can go from an endotracheal tube to a esophageal tube. So if you choose to go with a endotracheal airway, be very careful. Generally, we recommend that BLS airway should probably be used first, and if that's successful, that may be the most effective airway that you have. If you decide to go for an intubation, be sure that your tube is secured very carefully and is not allowed to be displaced, and is monitored frequently. End-tidal CO2 will help you determine if you have a inadvertent extubation. In pediatrics, the bags are very easy to over and hyperventilate with. Even the flow-controlled bag is not a fail-safe. So watch for chest rise. Don't ventilate any more than chest rise. Don't hyperventilate. Watch your timer. We have pediatric timers that are available. Those are set for 20 breaths per minute. And only ventilate when on the O2 timer, only ventilate when the light is on. The only pediatric timers that we're aware of is the O2, and the light shows you how long you should ventilate on those. There are other timers that are perfectly acceptable for adults. They only flash an LED when it's time to ventilate, so again, ventilate over 1 second in those patients. The other problem that we're finding is elderly. The elderly often have catastrophic TBI from relatively minor trauma, and if they have any TBI at all, the chance of mortality or the chance of death goes up astronomically. They're often on anticoagulants like Plavix or Coumadin. They can bleed with a very trivial head bump. They often are going to be resistant to transport, so this may be a patient that has a GCS of 15, doesn't want to go in, I'm just fine, goes on to develop a severe bleed and end up with dying from it. Keep a very high index of suspicion. If there's any external trauma, that's a good indication that that patient might have a severe internal injury in their head. And we don't even think of necessarily old patients. 60 seems to be the time when mortality goes up much higher. The older you are, the worse you recover from a TBI, and 60 seems to be kind of an inflection point. So be very careful with your elderly patients. Make sure they go in and be evaluated even for relatively trivial bumps. Doesn't mean everybody should need to go in, but it is a higher index of suspicion. This is an actual case that we reviewed. We've been pulling cases and providing them to agencies. This was the criteria that we used for this sort was pre-hospital diagnosis or pre-hospital GCS that was never below 13. These are patients that look alert, oriented, reasonably good GCSs. A lot of them have GCSs of 15, but they're diagnosed with a severe TBI on outcome. We also pulled cases that were high cost. So that generally indicates a higher severity of the injury, not 100%, but it's generally correlated with that. So we looked for cases that an EMS provider would drop off at the hospital, be totally unimpressed with that, go back to the station, think nothing ever happened, and it turned out the patient had a severe injury. Points to remember in this are that TBI is very difficult to identify in the field. Nearly all patients are EPIC patients, all trauma patients are EPIC trauma patients, and critically injured patients, TBI patients, often look totally normal early in care. The patient was a 24-year-old male. He had a motorcycle crash. He was wearing a helmet. He had some alcohol on board. He was lying when they found him on the ground. He looked great, alert and oriented. No loss of consciousness for bystanders. They did routine care, started an IV, transported him code 3, put him on a monitor, put him on oxygen early, did a great job. He was stable en route. At arrival to the hospital, he was still alert and oriented. He was going 35 miles an hour, had a few beers. The assessment that the medics gave, and this was concurred by the hospital, was that everything looked great. He was fine. Pupils were reactive. Everything was just fine. He had some abrasions, some minor trauma. I didn't include that slide. He had pain to the right side of the chest. Abdomen at that time was soft and non-tender. Vitals you can see there, but they were fine. Blood glucose was fine. They had him on high flow O2 within 6 minutes after they got their first set of vital signs, somewhere in there. It was very quick. Their on-scene time was 7 minutes. So they did a really quick evaluation and transport. They did an awesome job on it. But his outcome was not good. He ended up with a subdural hematoma, subarachnoid, intracerebral hemorrhage. He had lung contusion. He had a hemopneumothorax. He had severe liver and spleen injuries, a kidney contusion, and bowel injury. He also had about another 4 or 5 injuries that were lower significance that we didn't even include. This patient that was alert and oriented on scene looked like a nothing patient, ended up going to rehab or long-term care. They did an awesome job. They did everything perfectly. They had a great on-scene time, but this patient had a really difficult outcome. I don't know the final outcome now. Be really careful with those patients that are sneaky. They'll surprise you later on. So what our take-home messages are, I'll turn over to Dan to cover.
You guys have been great. We've gotten up in the 70s or 80s in the number that are out there, and nobody's dropping off. Impressive. So we just have a few more minutes here. So here are the keys. As you know, EPIC is really all about meticulously preventing and aggressively treating the 3 H-bombs, hypoxia, hypotension, and if the patient is intubated or has a subglottic hyperventilation. Don't allow your system to use what we've called ETCO2 monitoring that isn't. In other words, don't use your Untitled CO2 monitoring to just verify the tube that is in and then inadvertently document that you're killing the patient. We have seen that pattern over and over again, so really use it and really pay attention to it and carefully control ventilation from the first breath. That's one of the reasons why, even if you have Untitled CO2 and even if you have a ventilator, you should still use the flow-controlled bag and the ventilation rate timer from the very first breath before anything else gets started. And then if your system doesn't have at least ventilation rate timers and flow-controlled bags, this will probably create some questions, maybe even some outrage. But what we're finding is so many successfully intubated patients are so poorly ventilated afterward, we actually believe that if your system doesn't have at least ventilation rate timers and flow-controlled bags, you should not be intubating TBI patients. Because without these, all of us simply just hyperventilate, and that is profoundly bad for the neuron. So the target for end-tidal CO2 is 40, as you know, with a very tight range. But in the presence of hypoperfusion, this is what Ben did a great job of explaining and showing several cases. Don't treat the end-tidal CO2 if the patient if you're having to do unusually low ventilation rates in order to keep the end-tidal CO2 in range. That may well be an early sign that the patient is not getting good blood flow to the lungs, and that's why the end-tidal CO2 is low. So if you think they might be in shock, then use the ventilation rate timer, the flow-controlled bag, or the ventilator, and use the EPIC age-appropriate rate and volume. Other messages. The optimal blood pressure range may be much higher than has been previously thought and ever even hinted in the literature, frankly. And the 90 millimeter mercury hypotension threshold may not be real, and it may not be clinically, in clinically meaningful hypotension may occur at pressures that are much higher than that. And as we said, this doesn't change the official guidelines, but I think it does give us a completely different feel for how low we allow patients to go before we start treating. And then finally, patients with high GCS, but major mechanism, may end up having a major TBI with significant sequelae, very impressive injuries in the patient that Bruce showed us. So always have the high index of suspicion for TBI. And then endotracheal intubation is commonly the cause of hypoxemia in patients who were not previously hypoxic. So be aware that your intent to actually better care for the patient needs to be weighed with the fact that you can create hypoxia by doing the intubation. And then finally, and again, I'll just say, we'll drop our drawers, if you will, the study from the University Hospital in the state of Arizona that was just published in the Annals of Emergency Medicine. So this is a place where there's a huge focus, have looked at thousands of intubations over the years, all of the fancy widgets, and amazingly enough, if you don't pass the tube on the first attempt, you subsequently triple the likelihood of significant complications. And so even in the best of circumstances, multiple attempts is probably a problem. So move quickly to rescue if it doesn't look like you're going to be quickly successful on the intubation.
Yeah. So I actually want to congratulate and thank everybody on the call. As the call has gone on, we've had more and more people joining. The numbers just keep going up. So, you know, none of this stuff would be possible if it wasn't for all the EMS leaders and emergency medical care leaders that are on the phone and all the other people that in Arizona. You know, we feel really strongly that as soon as we get these data that are coming in, we want to share them with everyone. And I think you've gotten a flavor. This has just been some of the highlights of what we found already in EPIC. You know, we cannot yet even look at the outcomes, but I can assure you, as soon as we can, that's really what everyone, including us, really want to know is how this will impact survival and good neurologic survival, and that's really all of our collective goal. So as soon as we're able to look at that, we will be reporting back to you, but we will continue to have, we're really committed to continuing to feed information back to all our EPIC partners. So we will have in the near future additional webinars on more of these really kind of what we kind of call the cutting edge topics that everybody is so interested in. Most of these topics have been brought up to us by the people on the phone and all the people in the city, in the state, who have been bringing all this up to us. So I want to thank Bruce and Dan and Mike, and especially all the folks on the phone. We have been receiving some questions, so we're going to jump right into some of the questions here.
Before we do that, Ben, let's point out the CE credits and how to access them.
Thanks, Dan. So you'll see right there, if you want to get continuing education credits, you can email Saray Clark, and Saray will help you do that. We're also going to have this archived and posted on the Arizona Department of Health Services Bureau's website, where you can get continuing education credits as well.
So let me take on this first question. How is the data collection going, and are you able to start giving EPIC certified agencies QI feedback? So this is really, this is a perfectly timed question. The reason we haven't sent out QI feedback yet is until now, the vast majority of the cases, as you know, in the database have been retrospective. So they basically were the cases in your agency's first 5 years before they implemented, or 5.5 years before they implemented. And we didn't think it was very useful now that you've gone through the incredible hoops of implementing to waste a whole bunch of time giving you old cases showing that you weren't doing Epic care before you implemented Epic. But now we're starting, especially if you will get your 2013 data in, and that's starting to flow in from a lot of agencies now, we'll be able to start giving treatment, real treatment information and QI information back to you. And so just a couple of the kinds of things that you'll get. You will be able to get, obviously, overall demographics and so forth, but also outcomes and severity patterns within your agency. And then we'll also, if your agency is interested, we will look at specific and instructive cases from yours and include the outcomes in them and then get them back to you so that you can present those at case studies and so forth at your agencies. And then I think it's important for all the agencies that are in to know that we're getting close to doing the interim analysis, which is very important because that's where we'll actually first ask the question, what has happened to survival after implementing. So as the Epic data team and as Bruce and his team are getting in touch with you, please help us efficiently get that in. Obviously, you would hate to be represented only.
You've done all the work. You've done all the work, so we got to show the benefit.
We would hate for your agency to only be represented in your before setting. That would not be. That wouldn't help you much. So, great first question. Ben, do you have others that are there?
Sure. Let's see. And by the way, if for some reason we don't get to your question, we will send you an email with the answer to the question because we actually have several other questions. What's the next one you have, Dan?
Okay. So is there anything we should emphasize or do based upon these early findings from the EPIC project? So absolutely, I think, and I won't beat this to death, but I think what we found is intubated patients, even with agencies that have end-tidal CO2, a lot of us simply think, oh, we have end-tidal CO2 and we've had the training, so we won't hyperventilate. What we're finding is if you don't have somebody watch, in fact, that's why we've encouraged to have a spotter or what we call the VEMT, somebody that's on the team that actually is to watch the person who's doing the ventilating and to remind them to slow down. That's an incredibly important thing, and to continue to coach them through the ventilation. And then the findings related to hypotension, of course, and optimal BP, we don't know what really to think of it, frankly. This is the, again, when we, this ended up at the last section of the NAEMSP where they were talking about this with the EMS physicians from across the state saying, holy cow, we all been thinking, you know, as long as they're above 90, they're probably fine. This is the first data that's ever showed up like this. So I think it just emphasizes to be very sensitive. What we know for sure is a person who has poor perfusion does not do well with a traumatic brain injury. So if you think they're beginning to go into shock, treating them probably makes significant sense, even though we're technically not changing the guidelines.
Another question that was asked was whether paramedic CE is available. All you have to do is contact Surrey. We are not sending it out to all the attendees, but it is available from Surrey Clark. And also, if you have any comments, by all means, please send out comments to Surrey, and we'll note those. Nasal end-tidal CO2 accuracy, we are doing research on that, trying to find out. The statement from the attendee was that it seems to be low, and that's what we see also. We don't know the variables on that yet. We're working on trying to find out more information about nasal capnography in traumatic brain injury, and what we seem to be seeing is that we're seeing an increased use of nasal capnography. So that's very exciting to see, but we don't have enough data to know yet.
You know, I think it's important. The reality is, as we've looked around the literature, nobody knows what to think of nasal cannula end-tidal CO2. To me, right now, one of the major reasons to do it is getting used to thinking that end-tidal CO2 is a part of the care of traumatic brain injury.
It's a vital sign.
Absolutely. And so what we're finding is these agencies that are really adopting the, we really want to pay attention, we want to QI this, what we're finding is that the providers are starting to use it. So then, once they get the patient intubated, they're much more likely to pay attention to the end-tidal CO2. The other comment that's I think is appropriate for us to make is, if your agency wants input on how you might be able to QI your end-tidal CO2 as an agency, so that you, like these other early adopting agencies, can really maximize and optimize all of the hassle, if you will, you're going through to do the guidelines. It's a shame to have gone through all of these hoops. You get master trainers, you give all of this time, and it's really a shame to think that it wouldn't be doing it. So please contact us if you want information on how we can help you to be able to QI your end-tidal CO2 stuff at your own agency. Here's another question. Do you have overall numbers on how the project is going? Bruce gave that a little bit at the beginning, but just so you know, I believe we're now approaching 115 EPIC certified agencies in the state of Arizona. This is amazing, there are nearly 500 master trainers certified across the state. That's incredibly far beyond anything we would have ever dreamed, and shows the incredible commitment of your agencies out there. Well over 9,000 providers now, and we believe that's approximately 80% of the active providers in the state of Arizona. And then finally, as you saw, it appears that by the end, we will be able to analyze over 25,000 patients in the state of Arizona. And what we're hoping, of course, is we're going to show that we've actually saved potentially hundreds of lives because of what you did. One final thing that goes along with that question that I want to comment on is great work for all of you going into the hospitals and educating them. The reality is it's been 17 years now since the in-hospital guidelines came out, and frankly, it's embarrassing that 17 years later, lots of places have not yet implemented. So congratulations on a huge public health initiative where, think about it, EMS, I think, is really pushing forward the public health initiative in the state of Arizona, and actually getting many of the hospitals are starting to now ask, well, what does EPIC mean to us? So congratulations to everyone.
Absolutely. This is really a great case of pre-hospital actually advancing the science for in-hospital care. Dan, do we have time for one more question?
I think so.
Okay. So one more question. It's an interesting question in regards to GCS and sort of predictive value for severe TBI. And the question is, let me make sure I get it. Does the future hold promise to a device like the infrascanner being tested by the military or some other sort of point of injury testing schema? And I frankly, I'm not familiar with any of the latest technologies that could actually more accurately predict who has severe TBI or not. I don't know, Dan, if you're...
I'm familiar with some of those. Just so you know, so the concept is, what we all know is the reason why we want flow to the brain and the reason why we don't want hypoxemia is in about 4 minutes of the neuron not getting enough oxygen, it starts to die. And so the reality is, what would be wonderful to know is, do we know what the oxygenation is at the cellular neuronal level? And interestingly enough, there are some new technologies that are being developed that may be able to externally evaluate the intracerebral oxygenation.
Right.
And so, right now, most of those are very bulky and so forth, but I think that's a great question. And honestly, we could see the day where you actually could have a mobile device where, if you will, the 7th or 8th, at that point, vital sign is actually cerebral oxygenation, and it would help you manage your treatment.
Yeah, I also do know that I've seen some people that are trying to study point-of-care blood tests that actually would be perhaps predictive of brain injury. People are looking at that in not just TBI, but also stroke. I think it's pretty experimental right now, but it's certainly a good question and something that we'll keep our eyes open for.
So sometime in the next 24 to 48 hours, this will become, everybody will get an email that this will be archived. Please feel free to send it around.
Yeah.
Obviously, if it's useful to use at your agency, we want to make sure that happens, and we actually are going to be doing additional webinars in the future.
And we would actually be great if you could email in some ideas, some other points. Most of the things you heard today were actually directly, given to us by the EPIC providers and agencies. So if you have hot topics and questions, we will get those on the next webinar.
Yes, absolutely. In fact, right. So just to salt your wound of not having those answered yet, things like, should we use Trendelenburg? Some of these really fascinating. Should we do sedation? How much sedation is okay? Those kind of very controversial areas. The fact that we're not teaching to do mild, quote, therapeutic hyperventilation in patients who are herniating. The fact that we're not teaching that, those kind of things. So we'd be delighted, and feel free to send in your questions and your controversies, and that may help us drive the next webinar. So thanks to everybody. Our special thanks to Mike Sotelo, who is our data administrator, and most of you out there know him, for helping us put this on. Safe flying to those who fly, safe driving to those who drive, and take great care of your patients who have TBI.